Gaurav, are we live?
Not yet. I'll tell you. Yes, we are live now.
Okay, all right. Hello, everyone. Myself, Dr. Jasmine Marwaha, co-founder of Global Outreach Medical and Health Association, Global Outreach Forum of Endodontics, and Global Outreach Journal of Dental Research and Education. The Global Outreach Medical and Health Association is a global organization which has firmly established a leadership role in medical and health sector. So after having two successful days of our global interdisciplinary summit, we are heading forward today with another international renowned personality, that is Dr. Ameed Hamid. Talking about him, Dr. Ameed Hamid served as a dental advisor for the royal families in the GCC, lectures on oral health issues around the world, and is an advisor for the main health and beauty magazines and TV station in the Middle East. Dr. Hamid boasts an unrivaled reputation as of the world's leading clinician in the field of dental aesthetics. His expertise has been rewarded with a host of industry awards and appointments, which include Chairman of the Arab Academy of the Dental Aesthetics, Chairman of the Saudi Medical Forum Riyadh, Director of the British Centers for Excellence in Dentistry, Regent of the International Academy of Dentofacial Aesthetics, New York, Director of the British Centers for Excellence in Dentistry, and so on. So today he'll be taking sessions on updates on bad breath. So before moving ahead, I would like you guys to register yourself for CE at www.gomha.org. The participation certificate will solely be presented to all those who are compulsory a GOMA member. If anyone is not having GOMA membership, kindly register for it by visiting the site I have already mentioned. We will share a link containing a form which has to be filled in between the sessions. The form will be valid for 2 hours after the session ends. The form will be unique proof for the participant attendance for the respected sessions. After the submission of the form, the certificate of participation will directly be posted on your email address within 7 to 15 working days. Thank you. Over to you, sir.
Thank you, Dr. Jasmine. Good evening, or good morning, or good afternoon, wherever you are. It's really nice to be with this amazing and outstanding clinician. I would like to thank first the Global Summit for their organization, as well as the Global Reach for this fantastic organization of this virtual international conference. Today, I would like to talk about halitosis, or what we would like to call it in the UK, the malodor or bad breath. It's a challenging subject, I think, for all dentists and clinicians. Unfortunately, we do not get enough training when we were dental students. There is only 1 or 2 lectures in the whole 5 years course in any dental school about malodor or halitosis. This evening, or in this session, I'm going to talk about a research which been conducted between London and Riyadh on 1,000 patients. They suffer from this disease, the malodor or the halitosis or bad breath. And I'm going to give you the initial finding. We're still awaiting for the final statistical analysis and feedback from our clinical psychologist, one of the main authors in this research. So this, in my presentation, I'm going to talk about, first we'll go through introduction. I'm going to go through, when I went through all the literature review, the only amazing, really, classification and literature which can cover the whole is some of the studies done by the late Professor God bless his soul, my mentor, Professor Crispin Scully, and his co-author, Professor Stephen Porter from the Eastman Dental Institute in London. Then we'll go through some of the uh, some of the terminology used in some literatures. I will go through the study, some of the demographic information. We'll go to the association, symptoms associated with, because I would like to call it atypical malodor syndrome, not pseudohalitosis or halitophobia or other name you find in other literature. Then we'll go for the diagnostic criteria, therapeutic modalities, and the clinical implication. So, first of all, let's define the oral malodor or the halitosis. Well, it's very common. Uh, Most people have it, some elements in their life. There's between 8 to 50% of population, they have some kind of manifestation of malodor or bad breath in their life. I didn't cover in this session the morning breath because this is something really I think majority of people suffer from it when, especially during the sleep. Uh, Majority of us breathe as a mouth breather. The salivary gland secretion drops while we sleep. So majority of us wake up with a morning breath, which is not considered as a disease as such. Uh, but in the developed world, according to Mortella and Wang, there is, as I said, 8 to 50%, half of the population, they they suffer or they think they suffer from persistent, recurrent episodes of oral malodor. Now, the most likely, like 95% of causes of malodor or halitosis is the, as we know, accumulation of food debris, dental plaque, lack of good oral hygiene practice. So the dental plaque accumulate between teeth on the dorsum of the tongue, and this would result in gingivitis, periodontitis, and inflammation, which can also start the halitosis. Uh, it's there is no really age uh, reference. This can affect any ages, and when it's severe and long-standing, as I saw it in our study, it's not only decrease the self-confidence and the social interaction. I've seen people leaving their spouses, a wife leave her husband, or husband leave his wife, a member of the family keep isolating himself, becoming agoraphobic, a highly successful profession leave his job because he thinks he has this problem. Now, in order to understand the malodor syndrome, before we go into the malodor syndrome, let's go quickly on the classification, the most really accepted scientifically causes of malodor. As I said in the beginning, we find that food impaction come as number one. The most common form of inflammation in the mouth, which all we've seen, is the acute necrotizing ulcerative gingivitis, as we could see in this image. Acute gingivitis, adult and aggressive periodontitis, where you have a lot of bone loss and a lot of food debris and dental plaque stay there and create the volatile sulfur compound, which causes the malodor or the halitosis. Also, pericoronitis, and I'm sure majority of us seen so many patients complaining of pericoronitis. They present with a malodor. Also, dry socket, infected socket after extractions can also give bad odor. Lack of or dry mouth, I think the most common cause now, especially with the pandemic of corona and all the stress related, we could see xerostomia or dry mouth is the most common cause of having a transient bad odor or malodor. Uh, a lot of oral ulceration can cause halitosis as well as oral malignancy. Now, there is also some other, as far as the respiratory system, any foreign body into the respiratory system, starting from the larynx to lung. Sinusitis can give rise to halitosis, tonsillitis, any malignant tumor within the respiratory system, and also bronchitis can give a very uh, ingesting any food like garlic, onion, spiced food, durian, the fruits, which is famous in the way it produces the the halitosis. Now, a lot of systemic disease can cause uh, halitosis. Uh, any acute illness, as I said, respiratory tract infection. Uh, a lot of study, not sure. There's two schools about the Helicobacter pylori, which causes the peptic ulcer, ulceration in the stomach. Does it give halitosis or not? Two schools. One of them say yes. I am with the school which say Helicobacter pylori does not give halitosis. Any pharyngoesophageal diverticulum, gastroesophageal influx, when you have an influx disease, and also pyloric stenosis and duodenal ulceration can also give, but these are rarely seen in a dental setting or a dental practice. Of course, hepatic failure, anybody with liver failure or kidney failure, diabetic ketoacidosis, of course, can give you this fruity smell. Leukemias can give also the smell, the fish syndrome or the trimethylaminuria, and also during menstruation for women, they also suffer some kind of bad breath during the cycle. Also, drugs that can cause halitosis. You could see on the screen, starting from alcohol beverage to smoking to betel nuts to misuse of solvent by teenager, chloral hydrate medication, nitrates, dimethyl sulfur oxide, and some cytotoxic agent used to inhibit the immunity can also cause, plus the phenothiazine and amphetamines. All these medication can give also rise to halitosis. Now, what are the components that give rise to halitosis? Now, we have three main elements which can cause the halitosis. As I mentioned in the beginning, the most common one and the most well-known one is the volatile silver compound like methyl mercaptine, hydrogen sulfide, dimethyl sulfide, and the diamines. This is also another components, another byproducts of some of the microorganisms, especially AA, can give rise to halitosis, uh, plus the short chain fatty acids like butyric acid, valeric acid, and propionic acid. These are kind, and that's why sometimes you cannot really depends on halometer. The halitometer, if you want to use it, because it's only measure the sulfur compound, while the diamines and the short chain fatty acid cannot be detected by. The most common way of clinical assessment in a dental practice is we use a subjective, really. And we use what Professor Scully, God bless his soul, called it the organoleptic method. And this is where a clinician or assistant or your nurse or could stand on a like 1 feet or 2 feet and smell the patient when they talk and ask them to say ah from the mouth and smell it and ask them to exhale some air from the nose and smell. So you smell both the nose and the air separately, and easy to do, require no dental treatment. Now, the qualitative one, which is also called the hedonic method. Now, this is really require a very trained where you could differentiate according to the smell of the halitosis, whether this is a systemic, this is the ketoacidosis, this is fruity, this is ammonia-like, which is a result from renal. It's not really recommended use in the dental surgery. It's for highly trained and neither clinical judges. Now, the objective way which we use, as I said, if you detect the sulfite, which the main sort of the most common one we use is the halometer. Also, we use, as you can see in this image, this is the halometer blue, which is currently on the market. You could use also gas chromatography, which used for research. You could also detect all the three components which can cause halitosis. And also you could use microbiological investigation like bacterial detection using the polymerized chain reaction, the PCR, dark field microscopy, and other microbiological investigative tests which can help in detection of all the components. Now, in our dental practice, in a clinical dental practice for general dental practitioner or non, you know, specialist or not in a hospital setting, it's normally subjective. And as I said, you ask the patient to smell the exhaled air from the mouth. If it is only from the mouth, which we call the organoleptic assessment, if it is only from the mouth, not from the nose, if you smell this bad halitosis, bad odor, malodor, coming only from the mouth, it's more likely either oral or probably pharyngeal origin. If it is not present in the mouth, but only from exhaling air from the nose, this means it's really to do with the respiratory system. And very rarely when you could smell both uh, bad breath from nose and the mouth, it's probably an indication for systemic cause of halitosis. Uh, and what is the treatment? Well, as I said, unfortunately, the majority of dentists, they check periodontal health, they try to give patient oral hygiene instructions for scaling and polishing. Uh, it's very important to investigate and manage if there is any systemic non-oral disease. Uh, and you could use this technique, which I mentioned, the organoleptic method. You have to ask your patient to improve their oral hygiene and monitor and retrain. Uh, Regular atraumatic. Unfortunately, in the research we've done on 1,000 patients, because they having a different, we're going to talk about it, but like majority of them, they lost their tongue papillae or they have hyperatrophy because they use this tongue scrubber in a way that is not recommended. So when you recommend your patient to use a tongue scrubber or use the brush, they have to do it very gently in order to avoid losing some of the important papillae which we use for tasting our food stuff. Some recommend antimicrobial toothpaste and mouthwashes, chlorhexidine. Majority of patients doesn't like chlorhexidine mouthwash because stain the teeth and also give burning sensation, but it will give at least a good 2 weeks of because it can kill the microorganism which causing all the stuff which cause halitosis. Maintenance, effective oral hygiene important. Now, the atypical malodor syndrome. This is what we're going to talk later. It's a very unique syndrome, and some authors and some clinician has suggested successfully using of soft laser and UV light treatment to kill the microorganism causing halitosis. Atypical malodor syndrome, it's why we call it syndrome, because it's combination of more than one illness. So when it is more than two, you call it syndrome. Some in the old studies, some of them they call it pseudo-halitosis, non-genuine halitosis, delusional even halitosis, olfactory obsession, psycho-olfactory sensitivity, or olfactory depression, and halitosis and anxiety and imaginary halitosis. I don't like this terminology. That's why I'm calling it atypical malodor syndrome. Now we are conducting a study with the with the, in joint venture with Tel Aviv University, where we want the null hypothesis that patient does not smell. Patient with atypical malodor syndrome does not smell. It's an imaginary. Well, it is not. I mean, seeing 1,000 patients with this condition, I could tell it's not they smell it in a way, because the majority of them, they have what we call it a failure of controlling stress. When they fail to control stress in their life, the whole immune system will change. Some of the neurotransmitter which transmit the neurotransmitter from the olfactory center to the brain could give the patient a real smell of a bad odor or a malodor or halitosis. So it's not an imaginary, it's not a delusion, it's actually a real. And we're still awaiting for this research. Will take probably another 3 years to finish. Now, going through this patients, we studied 1,000 patients with what we call it atypical malodor syndrome. Uh, 49% of them were male and 51% females. Age distribution, majority were between the age of 26 to 45. However, there's some patient less than 16 and between. Of course, in this study, we only studied the atypical malodor syndrome, which I'm going to discuss the exclusion criteria. A duration of complaint, normally you see here the majority between 5 and 15 years. So it's a long suffering. Uh, these patients, they run from one specialist to another, and they isolate themselves and, in a very bad situation. Now, what is the association? Why do we call it syndrome? Because majority, really 92% of them, they suffer from irritable bowel syndrome. This is one of the associated symptoms. Nearly 90% they suffer from migraine or severe headache, some kind of headache. Again, 90% they suffer from neck ache and backache, and probably 85% they suffer from itchy skin or eczema. So these four associated symptoms is normally always one presents either one or two or four of them. We ask these patients, do you really suffer from stress? And the majority, they suffer from stress. Some of them, they will say, well, I'm stressed because of having halitosis. But reality, it's not a stress. It's the failure of this patient to manage stress, because we all stress. Life is a stress, but it depends on how do you process the stress. Can you manage it or let the stress manage you? And this is the difference between a patient who can suffer from stress and patient who could successfully manage stress. And of course, all the current data tell us that the majority of disease, including neoplasia and cancer, caused by failure of handling stress. Now, the majority of these patients, the 1,000 patients, they've seen more than 10 specialists during their suffering. As you can see in this bar chart, less than 5, between 5 and 10, nearly 30% of them, and nearly 70% they've seen more than 10 specialists during their suffering. Now, when we ask them what kind of dental treatment have you had for treatment of halitosis, half of them, they had some kind of hydrogen peroxide or carbamide peroxide treatment. 15% soft laser therapy, which is very successful in treating the genuine halitosis. 75% some kind of periodontal debridement. 88% they had root canal treatment, and I'm not sure whether this kind of root canal was needed or not. We cannot really justify it. Quarter of the sample had some kind of extractions. Majority have scaling and polishing. Uh, all of them, they prescribed some kind of mouthwash, and 75% the dentist said, sorry, I can't help you, so refer to a medical specialist. We asked them, do you ask your family about it? Now, my observation during this study, I've noticed patient with atypical malodor syndrome, because he can or she can smell it, they are first, they feel ashamed of it. Second, they don't want to ask any member of the family because they think they will become nice to them. They don't want to upset them. They don't want to. So they do not ask their family about it, and they live with it. They isolate themselves, and as you see here, nearly 100% of them, they do not ask their family about whether they can smell their halitosis or not. The worrying thing which I discovered that all of them, really, more than 76%, they are using metronidazole antibiotic, the flagyl, and they use it, some of them more than 10 courses, majority between 5 and 10 courses. And as we know, usage of this excessive use of, and they believe it will make their tongue pinkish more, remove the white layer, which is because of course, because of a dry mouth, and also of its hepatic poisoning if you use, and also of the antibiotic resistance. So this is something which really, I always, this, I always ask them to discontinue any kind of antibiotic because it doesn't work. It's just psychological. All of them, they suffer from white coating of their tongue, and they believe this white coat represents, germs and bacteria, which causes the halitosis. And actually, in reality, it's not. It's the xerostomia, the dry mouth, because they fail to control their stress, so that's why they have always a dry mouth. I mean, any patient with atypical malodor syndrome, they have the golden medal for oral hygiene. If you see their mouth, it's like excellently maintained. They use brushing more than twice a day. They are, as I said, the golden medalist in the flossing. They use, unfortunately, mouthwashes as if there's no tomorrow. And besides, they use other, like, as I said, of course, majority of them, they use tank scrubber, and some of them in the Middle East, they use something we call miswak, which also some kind of oral hygiene apparatus. When asking them, is it 24/7? Is it more in the morning, less at night? The majority of them, they say no, it's just there, the same intensity 24/7. And this is one of the indication for you, as this is a typical malodor syndrome. What was our inclusion criteria in the study? Well, we only choose fit and well patient with no systemic or any medical condition. It has to be more than 2 years duration, the problem. And they tested negative to organoleptic assessment, smelling by the clinician, the halitometer, and the PCR, the microbiological investigation, which we've done, and has more than one, as I said, one associated stress-related symptoms, which we called, that's why we call it atypical malodor syndrome. Atypical malodor syndrome is a real challenge for our dental profession. Unfortunately, nearly half of the sample we studied went collectively and necessarily they went open with endoscopy and other not needed medical intervention with several courses, as I said, because neither us and nor the medics we get enough training on halitosis in our dental organs. That's why you see poor patients with malodor syndrome will go from dentist to internal medicine, gastroenterologist, to ENT specialist, and the majority of them have hysterectomy, and they have excellent health. As I said in the beginning, unfortunately, 65% of them they have some kind of tongue papillary atrophy or hyperatrophy because they use the tongue scrubber in a very vigorous way. And some of them they lose some kind of taste sensation, the accuracy of sensation when you have tongue papillary hyperatrophy or atrophy can affect your taste. Well, early indication from this study showed that I'm still awaiting for the final analysis from our medical statistician, but 45% they respond very well to just reassurance because they don't ask and they presume they have it. And as I say, when we are sympathetic and we know they smell it, but the good news, this is what I say to them, you are the only person who smell it. So when my nurse gives them the positive, and when they go home, they ask their spouses, member of the family, and they say, "You don't have it." And nearly half of the sample they respond extremely well to just reassurance. 35% respond beautifully to the cognitive behavioral therapy (CBT) by our clinical psychologists. They've done very well. 10%, the most difficult cases, we refer them to our learners and psychiatrists for some education to control it. And unfortunately, 10% is still struggling with my conclusion always involve a family member.
Sir, there are some echo problems. You have to adjust your voice volume.
Is that better now?
Sir, there's bit disturbances. You need to adjust, sir.
Sorry, this is my last slide anyway. Can you see it? Is it okay now?
Sir, your volume is very low. There is a bit echo from your side.
Okay. Is it better now?
Yeah. Yes, sir. Perfect.
So as I said in my conclusion and my last slide is always involve the family when you discuss, because as I said, they will get some reassurance when a family member say to them, well, you don't have it. It's sometimes majority require multidisciplinary approach involving clinical psychologists who with you on board will be a fantastic step. As I said, reassurance, it's one of the treatment options as we've seen. And in our next summit meeting, I'm going hopefully we'll present the final analysis and final data. At the end of this presentation, we'd like to thank you all for giving me the chance to meet with all your fantastic audience. And I'm happy to take any questions. Thank you.
Thank you, sir. It was really a wonderful session.
Thank you.
It seems everyone wants me to express appreciation for your session. It was really a great session full of energy, very knowledgeable.
Thank you. Thank you, Dr. Jasmine. Thanks for your kind introduction and for giving me this chance to meet with this fantastic audience. From Riyadh, from Arabia, I would like to send my appreciation and thank you. And
Thank
if
you, sir.
anyone who would like to ask any questions, I'm happy to answer.
Sir, I'll let you know. There are no questions yet.
Okay.
And we are grateful for the time and effort you took to share your thoughts and experience in this summit. And thank you, sir. Thank you so much.
Not at
And
all. It's my pleasure, Dr. Jasmine, and I wish you all the good luck in the rest of this meeting. And would like to thank you and thank your organization and the Global Summit for organizing this fantastic
sir, I
meeting.
got one query.
Yeah.
What devices do you recommend for in office?
Well, as I said, uh, because the malodor or halitosis, it's not only caused by volatile sulfuric compound. We have another two components which cannot be recorded by the halitometer. The halitometer, it's fantastic only to detect the sulfur, volatile sulfur compound. So the best thing is to use your own judgment by, as I said, use the technique where you smell the patient breath first from the nose, second from the mouth, and third, ask them to exhale both from the mouth and the nose, and then decide and double check with your nurse. I think this is the most probably useful tool. Some of them suggest the halometer. Now we have in the market the halometer blue, which is good, but unfortunately, this device will miss the other two components, as I mentioned in the beginning. It's not only the volatile sulfuric compound, but also there is another, the amines and the other components. So use your own judgment. It's the best.
Thank you so much, sir. Thank you very much.
Thank you.
So we'll be back with our next session in few minutes. For more information regarding certificate, registration, speaker schedule, visit www.gomha.org. Till then, stay tuned, everybody. Thank you.
Thank you.
And I'll be ending the meeting.